So Maria is a midwifery educator and PhD researcher at Robert Gordon University in Aberdeen. She originally qualified as a midwife in Spain in 2013, and she has developed the majority of her clinical and academic career in the UK. Since 2018, she has contributed to the improvement of maternity services by educating future midwives in feminist, woman person-centered care and autonomous midwifery practice. So I'll leave Maria to introduce the title of her topic today, but Maria, you're very welcome and we're pleased to have you as part of VIDM 2026.
Thank you very much, Ali, and thank you very much for the welcoming and the organization for allowing for this space where so many of us across so many different places can connect. It's really lovely to see a space for midwives to connect without borders. So thank you for organizing that. Today, thank you for joining me and thank you for the interest in this session. As the introduction says, I'm a midwifery educator and researcher. I'm finishing my PhD, and today I'll be sharing preliminary findings from this PhD research, where I was exploring UK midwives' attitudes and experiences of freebirth. Listening to midwives' voices on freebirth, for me, illuminated tensions in birthing freedom in the UK, and it gave us data on how women and midwives' autonomy are closely linked. So today I will be sharing preliminary findings from my research to illustrate how, if midwifery isn't free, some women might choose to birth without us. But let's start by what is free birth and why did I choose to explore how midwives feel about it. First, there isn't a single agreed definition of free birth, but broadly we are talking about a deliberate, planned decision to give birth at home without a regulated healthcare professional. And this is a term that we usually use in contexts where access to maternity services or emergency maternity services is reasonably available. Under this umbrella of the term free birth, we have put many different things together. So some authors talk about free birth to include self-care birth, where women self-care during the birth and they don't rely on external roles. But they also have included, some authors have also included birth with unregulated birth workers or birth with traditional midwives. This is not a new phenomenon. The first documented accounts of intentional unattended birth appeared in the 1950s in the United States in a context of high medicalisation and limited choice for women. So not surprising, this resonates with some of the issues that we have nowadays and might actually explain the renewed visibility of free birth, particularly since COVID-19. In public and academic discourses, and you can see some examples of media pieces from the UK and actually, they are all from the UK, I'm thinking now. In public and academic discourses, free birth is often framed as a controversial choice and is raising ethical debates about the boundaries of women's autonomy, but it also reflects underlying cultural beliefs about risk and safety. And despite the fact that we do not have reliable outcomes on data, as you can see on the media pieces, on the public discourse around free birth is often focused on warning about the dangers of this practice. But as I say, we do not have reliable data on outcomes. 2 years ago, I was lucky enough that the Virtual Day of the Midwife Committee actually accepted also a presentation. So 2 years ago, I presented a review of the international literature on why women free birth and how do they experience maternity care. That review, which I'm not going to go in detail now, the video is available on YouTube and also the paper is available open access. That review set the stage for my study, my research study, because it illuminated how midwives play a significant role in women's decision to free birth, either by enabling their choices or by actually experiencing barriers in supporting women's requests for their support. But, sorry, that's moving between screens. Beyond a limited number of publications, which are mostly anecdotal data and opinion pieces written by midwives, the opinion of midwives on free birth is not clear. And in general, the published editorial pieces on free birth reflect two trends, either midwives expressing cautions about potential risk of unattended birth, or in most cases, midwives framing free birth as a sign of systemic maternity care failures and failures to support personalized care or to support physiological birth. And free birth is often framed in these pieces as an attention call for midwives to critically examine our role in the increasing medicalisation of childbirth and the lack of woman-centered care. And while this is anecdotal data that give us some insight into how midwives feel about free birth, it's clearly insufficient to actually understand not just how midwives feel, but also how they provide care for families who are making the decision to birth unattended. And this is an important gap in the literature because our attitudes and experiences can directly influence women's choices and their ability to exercise those choices. And this is the gap that my PhD study aimed to address because I aim to answer those three questions that you can see on the slide. How do midwives feel about free birth? How do they experience providing care to families considering this? And where are the contextual and sociocultural and political factors that influence midwives' perspectives around this topic? I used a feminist mixed method study with two phases. The phase one was the qualitative phase where I interviewed 40 midwives in the second half of 2022. And building on the themes from this first phase, I built a survey that I ran in January 2025 to capture a wide-angle cross-sectional picture of midwives' views on free birth. And I had a sample of 480 midwives, which was fantastic and a fantastic response to my study in just 1 month, which also shows the interest of midwives to talk about this topic. In both phases, the participants were recruited online. I used social media and snowballing through my own professional and personal networks. And what I'm presenting today is an integrated summary of preliminary findings across both phases of the study. Before I tell you about my preliminary findings, it's important to acknowledge the context in which this study was conducted. Because UK has a long and internationally recognized tradition of midwifery, maternity care is publicly funded through the national health system, and technically, and I say technically because as I'll mention in a second, we'll have some restrictions recently, but technically it includes access to hospital birth, midwifery birth units, and home birth. Midwives in the UK are the lead professionals for most women during pregnancy. They provide care across the whole continuum of care. And we also work in collaboration and coordinate care with a wider multidisciplinary team for women with complex needs. Since the 1990s, maternity policies in the UK have been explicitly shaped about the principles of choice, control, and continuity of care. And it's about aiming to support women's autonomy and personalized decision-making. But this vision sits with a system that is currently experiencing a profound maternity crisis. We had over recent decades, maternity services have faced sustained underfunding, workforce shortages, and we also have rising levels of intervention and increasing medicalisation of childbirth. And this has been also compounded by a series of high-profile maternity safety scandals that you might have heard about, and national investigation, which have exposed serious systemic failures and undermined trust in maternity services. And at the same time, we have deep social inequalities in this country with very clear evidence of discrimination and worse outcomes for women from marginalized and racialized communities. And alarmingly, our maternal mortality rate is increasing, particularly among disadvantaged groups. So it was in this context where I recruited my participants. And we can see the participants from phase one in that slide. Phase one midwives had all diverse backgrounds, experience, clinical roles. Most of them worked for the public health system, the NHS. 2 were independent midwives, and most were experienced clinicians with more than 5 years on the register, but 2 were on the first year after qualifying, and 1 participant was also a paramedic in addition for being a midwife. Most of them work in the hospital. 1 midwife had a specialist post in clinical governance, and 1 midwife had a leadership role as a consultant midwife. And apart from the independent midwives, only 2 midwives on the NHS work in full continuity models. For phase 2, responses came from all 4 UK nations, and I'm very proud that pretty much every postcode on that map is covered. So I cover most of the postcode areas with some small hotspots likely due to snowballing. The sample was not intended to be statistically representative, but I worked to maximize diversity. Compared to the national demographics, Scotland and Wales were somehow overrepresented, and we also had more responses for older midwives, 41, 54, 55-year-old. Asian, Black, and internationally educated midwives were under-recruited, and that is a strong limitation of this sample. Most of the midwives work in the NHS. They had diverse levels of experience, including midwives at very senior leadership positions like consultant midwives or heads of services. And the biggest group of participants were community midwives, followed by obstetric unit midwives and midwives working in continuity models. In addition, I also captured the views of 7 independent midwives who work exclusively in independent practice and 2 work exclusively in private practice. So what today I'm presenting is the preliminary findings that I'm still finishing writing up. And what I will be discussing with you on these preliminary findings is what midwives reported about their exposure of free birth and how this can be used as a limited proxy measure for occurrence and presentation of free birth in the UK, how their perceptions and experiences point to issues with home birth access and access to personalized care in the UK, and how these reflections and the midwives' reflections reveal a wider context of professional oppression and medicalisation of midwifery in the UK. So having outlined those main 3 themes that frame midwives' experiences of free birth, I will then discuss how their responses to free birth, how midwives react to the women's decision to birth unattended, reflect different strategies of adaptation to that narrower context of professional and reproductive autonomy in the UK. Let's start with exposure. This was much higher than I had anticipated. I knew that free birth was more common than we previously thought, but I was very surprised by the fact that 7 in 10 midwives in the survey had exposure to free birth cases. And in 4 in 10 cases, midwives have been directly involved in providing clinical care. So this figure suggests that free birth might be more common than we have previously estimated. And for comparison, a study in the Netherlands in 2018 reported approximately 10% only of midwives have had requests of support with free birth. So quite surprising, much more common than I had anticipated. Yet for most midwives, free birth was a rare event, and most of them reported less than 5 cases in the previous 5 years. Community midwives were more likely to have direct exposure and direct experience to free birth cases, suggesting that most free birth care remains in the community. And the most common reasons for midwifery care were antenatal and postnatal care, mostly routine care before and after pregnancy. And this demonstrates, once again, apart from the literature review that I presented 2 years ago, that actually free birth is not the absence of care, because women seem to be seeking midwifery support in pregnancy and after birth. Half of the midwives with direct experience also reported providing interpartum care, which also suggests that women are seeking midwifery support during birth if they feel that they require that support. And it was mostly in the context of transfer and complications in my survey, in my sample. And this pattern of interpartum care in the context of complications might also explain the outcomes that midwives reported for the free birth cases in which they have been involved. Not here. So midwives reported different outcomes from their free birth cases. These outcomes were based on the recollection of cases and might reflect outcomes across multiple cases in which they might have been involved directly or indirectly. Uncomplicated birth remained the most frequently reported outcome for the cases in which midwives have been involved. But it's true that a significant proportion of midwives also reported complications, like the physical complications that you can see on the slide, social and psychological complications, mostly issues with notifying the birth and accessing NHS service for the baby, and social services involvement. And some also reported experiences of perinatal mortality outcomes. But I will advise caution in interpreting these results for 3 main reasons. First, midwives appear to be more involved in cases that were complicated and the complications prompted the access to care, where maybe uncomplicated free birth remain unknown to them. Second, these outcomes are based on the recollection, and it's commonly recognized that we might recall events that are more emotionally loaded, such as dealing with an emergency or dealing with a perinatal death. And also that this data is coming from a survey that was not statistically representative, and some of the perinatal mortality outcomes from the data, it seems that they are coming from the same clinical area, one of the hotspots for participant recruitment. So it is also possible that multiple midwives have been involved in the same case, and that's why they were reporting those outcomes in this study. But despite having an experience of these complicated cases, or having this exposure to complicated cases, midwives' primary concern wasn't simply risk, it was something deeper. Sorry, I forgot to mention that actually we can't draw any conclusions from those outcomes from midwives, But what is reflecting simply is how midwives are involved in these cases, because midwives are the safety net for women and families who are considering free birth. But as I said, despite this exposure to perhaps more complex cases, midwives' primary concern wasn't simply risk, it was something deeper. Midwives were more concerned, and that was the most important concern in relation to free birth, about the loss of trust in maternity services and how families might be choosing free birth because they cannot access the preferred birth choices, as illustrated in some of the quotes that you can see on the screen. 3 in 4 midwives have perceived an increase in free birth since 2020. And many are describing free birth as a plan B, not as a first option, not as the preferred birth mode, but a plan B that women are preparing for when services are unreliable. And this is mostly due to last-minute home birth cancellations or lack of access to midwifery units because they were closed. And midwives reported that women in their care were feeling cornered and therefore were preparing for free birth as a possibility, not as the first choice. And this actually also touched midwives' own reproductive decisions. So across both phases of my study, some of the midwives had free birth themselves. And for many, this was not the preferred option. And these numbers are small, but for me, this finding is significant, because if midwives who have an insider knowledge of maternity services cannot secure the preferred birth option, this might signal significant barriers to facilitate reproductive choices within current maternity care in the UK. So in this context, how do midwives feel about providing care and support during free birth? So perhaps because of the experiences of complex cases, midwives express divided opinions about providing backup care in free birth. More than 60% of them agree to attend a free birth when called for help, but less than half supported being on call for free birth, or even supported providing support over the phone. This could be explained by the concerns midwives had, including worrying about walking into unknown scenarios, fearing having to manage complications when families might be declining care and how to navigate that. And other midwives also opposed being on call for free birth because in their view, this was to treat midwives as emergency responders. And these midwives argued that emergencies should be managed by paramedics or in a hospital setting. And some felt that being asked to turn up only to perform emergency procedures undermined the relationship-based nature of midwifery, but also put them in a very difficult position, and it was adding pressure to already overstretched services, as illustrated in that first quote. Like the expectation that we will sit outside and wait to be called is unrealistic in a service that is overstretched. There are other women who want and need midwives care. So despite otherwise supporting women's right to free birth, being asked to provide backup care or attend free birth appears to be quite a controversial issue for midwives and when they felt most vulnerable, with midwives reporting adding stress and feeling the potential to be blamed. In fact, when thinking about free birth, most midwives, 80%, reported feeling negative repercussions on themselves if they were to be involved in free birth cases. And that explains why they were also careful not to appear to endorse free birth or to encourage free birth, because they were fearful of experiencing negative repercussions. And the potential to be exposed to these scenarios generated really strong emotions in some midwives. And as you can see on the slide, I feel very angry that I have no choice but to attend and expect it to be clear, to clear up the mess. And the problem is that when midwives could not meet women's needs, they express concerns about the emergence of alternative forms of birth attendants that might be stepping into this gap. So midwives worried about doulas or unregulated birth workers spreading misinformation, overstating competencies, or causing delays in seeking care. And some midwives reported cases of adverse outcomes in birth supported by unregulated birth workers, or where parents have been falsely reassured by the advice of these unregulated birth workers and delay seeking care. So they actually felt that the presence of these unregulated birth workers was more troubling than free birth itself. And while some midwives acknowledge the contribution of doulas and unregulated birth workers and the positive impact that they can make in supporting women's choices, midwives also share concern about how these emerging forms of birth attendant might be gradually displacing midwives and crossing the boundaries of the protected title of the midwife. And this distinction led midwives to differentiate between true free birth from doula-assisted birth. And for some of the participants, this tension between doulas and midwives appear to be rooted in the increasing medicalisation of midwifery in the context of industrialized, risk-averse practice that narrows autonomy for both midwives and women. Because, sorry, one second. My mouse is gone sadly here. Across both phases of this study, Freebirth exposed really profound tensions in midwives' ability to provide woman-centered care in the UK. Midwives wanted to uphold women's reproductive rights, but they were increasingly constrained by a context of medicalized and risk-averse practice that ultimately compromised their ability to be with women. They expressed frustration with the closure of midwifery units with home-based services that are the first things to go under system pressure. They felt constrained to work with strict guidelines, and they expressed high levels of frustration with how this tightly regulated environment is protecting the needs of the system more than actually women's needs. And even when midwives wanted to support personalized choices, they felt that the practice was tightly controlled by a culture of surveillance that made midwives feel scrutinized in their practice. Midwives live with a sense of hypervigilance to demonstrate that they were working with these narrow parameters of practice, and fear of losing their registration appeared to be quite prevalent, and it actually influenced midwives' defensive practice. And subtle threats to fitness to practice referrals appear to be a mechanism of controlling midwives' practice in a similar way that social services referrals were used to coerce women to comply with recommended care. And this was not the only mechanism of controlling midwives' behavior. They also talk about bullying and horizontal violence from their colleagues, and a culture of toxic environments in which midwives that seem to descend from dominant medical risk-averse practices are stigmatized or ostracized by their colleagues instead of actually praised for supporting women's choices. And this led to some midwives feeling pressure to act against their value to protect themselves from judgment. So while Freebirth might not make midwives fully uncomfortable, what makes midwives uncomfortable is that Freebirth decisions made these structures of oppression much more visible. In this shrinking space for birthing autonomy, for midwives' autonomy and women's autonomy, both women and midwives employ different strategies or responses to this oppression. So I call them in, within, or out. So in is in a system that leaves very little space for choice or autonomy. Both women and midwives try to find some power and some control inside the system. For women, sometimes this might mean requesting elective cesarean births to remain in control of their birth. For midwives, this in the system meant sometimes abdicating their midwifery values, and they end up internalizing medical definitions of their role. They move from woman-centered care into fetus-centered care, essentially becoming the oppressor. So some midwives in this response or adaptation to oppression express actually very strong opposition to free birth that materialize in displaying coercive behaviors to get women to comply with care, considering free birth as a safeguarding issue for the baby, and justifying blanket approach referrals for social services. And these views were not dominant. They were a minority within my sample, but they were seen as highly influential in shaping the discourse within maternity services. So most midwives within my sample were in the response of within. Within refers to how both women and midwives use subversive practices to navigate some autonomy and try to protect women's rights within the system. Those subversive practices for women could be using selective engagement and more requesting and trying to negotiate outside of guidelines care. Midwives using this approach, what they try to do is they advocate for women. They help women achieve their choices within the system. They work to build trust with women, and they enable those outside of guideline choices for women, or they facilitated access to women when they wanted. But doing this, midwives were also very aware of considering the system realities, including how to shield women from that resistance or opposition to free birth, but also how to protect themselves from potential blame or negative repercussions. So despite being committed to supporting women's rights, many midwives feel that their support for women's right to choose free birth had to remain underground, drowned by those system-centered voices. And sadly, the tension of working a little bit underground within the system means that some midwives will consider leaving the profession. So some women will leave the system because they don't find the support, and they choose to free birth because they're not finding the support, or they birth with unregulated birth workers. But for midwives, the moral injury and the grieving of the professional autonomy that they used to have as midwives meant that some midwives are leaving the professions because they cannot practice midwifery. And some of them had considered or have gone into unregulated birth work to be able to continue practicing with women midwifery that they could not practice within the system. And actually, multiple participants have talked about known cases in their local areas where ex-midwives are now acting as unregulated birth workers. So, what Freebirth is exposing, as the quote says, the politics and power relations of birth are most often visible only when someone resists them. And in the UK, Freebirth is exposing an increasing medicalisation of midwifery, a loss of professional autonomy for midwives, and a loss of reproductive autonomy for women, and also a system that is crumbling. So while Freebirth might not make us uncomfortable, these tensions exposed by Freebirth do. That's what we feel uncomfortable about, what Freebirth is exposing. The question now, and this is the part I'm struggling with as I'm writing my thesis, is where do we go from here? Because Freebirth is not a rejection of midwifery, it's a call for greater midwifery and greater reproductive freedom. And if midwifery is not free from systemic constraints, it cannot be for all. We need to reimagine care to prioritize autonomy, to prioritize continuity, and to prioritize trust, because that is essential to enable midwives to practice. That's my 5 minutes? Yeah. That is essential to enable midwives to practice without fear and to make midwifery for all a reality. And this is not a call to minimize safety. It's a call to center safety in the relationship-based person-centered care, the heart of midwifery, and to ensure that the service that we have do not inadvertently produce the risk that we are actually trying to avoid. I want to close this presentation, closing the circle with a quote that will actually open my dissertation. This is a quote from Rochelle Chadwick, and it says, "The struggle for birthing freedom involves the freedom of all who take part in birth. Birth will never be an experience of freedom as long as those who care for birth are unfree, devalued, oppressed, or exploited in their labors." So maybe it's time for us to stand up so women can have their choice supported, so they don't need to feel that free birth is their only option, and midwives can support them with their choice, and they don't have to feel that they have to leave the profession to practice through midwifery. So I encourage you all to join, stand up, and fight for the profession, because we need to stand up for this. And thank you very much for all your attention and patience, and I'll invite you to get in touch, and I now open the forum for questions, comment, feedback that will help me refine my writing.
Okay, thank you for delivering such an insightful and engaging session. We truly appreciate it. And I found this question on a chat box from Khadija. The question is, could psychological disorder among pregnant women can increase this free birth, like types of phobias or anxiety? You may answer it directly.
We don't have any evidence around any type of demographic for women. So we actually don't know if they are more likely to experience any mental health disorders than women who choose to birth in hospital. We do know that previous traumatic experiences tend to lead to distrust of services, and it's not always the case that a previous traumatic will trigger someone to decide to free birth, but previous traumatic experiences of birth or birth care, obstetric violence, disrespect and abuse tends to be related to women then deciding to free birth because they feel that they can no longer trust maternity services. So it's not like it's a mental health condition leading to this. We actually don't know anything, mental health or physical health for women who free birth, because we are not collecting the data. But we do know that trauma tends to be a strong factor in women then deciding to free birth. But even that, most women still don't want a free birth. They are trying to seek a safer birth with midwives. So they might be perhaps are looking for a home birth, but then our home birth services are constantly cancelled, so they are not reliable. Or they might want access to a midwifery unit, but they might have risk factors for something, so they have access to those midwifery units restricted. on some risk criteria. So they end up deciding to free birth because we are not able to provide personalized care within the system. And we give them no other choice than to do it on their own.
Okay, so the answer might help you, Khadija. Okay, so maybe the last question from Sandra William. In the US, certified nurse midwives practice in hospital, birth center, and home. Is hospital birth the only option for women in UK?
No, it's not. And that's why I'm saying our policies actually recognize, and we do provide home birth services, and we provide midwifery unit services. So our clinical guidelines says that women should have access to all 4 options: midwifery units, freestanding midwifery units, birth centers within hospital, home, and hospital birth. The problem that we have, and if you go on Birth Rights, they recently published a report, is that we have widespread cancellations of home birth. So home birth has become not reliable. It's an option on paper, but we don't know if it's an option really on the day women go into labor, because either we might not have the staff, or the staff might have been pulled into the hospital, or the service might have been cancelled, and we don't know when it's going to be up. So it's not reliable. So it's an option on paper, but the reality is that it's in many areas of the UK, it's unpredictable. So women don't risk it. They say, well, if the home birth service is available on the day, I'll have a midwife and I'll birth with a midwife. But if I call the unit and they say there's nobody to send you out, I'm not going in. I'm just staying home and doing it on my own. So it's a plan B that they prepare for.
Okay, thank you. So we have 3 minutes left. So there's one last question from Celine Lemay. Oh, it's not a question. It's an encouragement.
Oh, good. Yeah.
To claim autonomy and assuming it as midwives. Thank you for everyone.
It's a very clear relationship. If we don't have freedom, women don't have freedom. It goes hands in hand. So we need to work together, not split apart.
Yes, indeed, agreed. We need to stand up for each other.
Mm.
Okay.
Yeah.
So maybe we come to an end.